All right. Would you agree that all perpetrators of IPV have anger management issues?
Yes.
And a large portion of IPV perpetrators have substance abuse issues?
It's one of many factors that correlates with intimate partner violence, but there are certainly many people who perpetuate intimate partner violence who do not have substance abuse issues.
All right. Of the 5% that are IPV perpetrators that you've treated over the last 8 years, how many of these perpetrators have substance abuse issues? And your answer was?
I see that I answered with a figure of speech, a large portion.
Okay, thank you. And it's common for the perpetrator to essentially gaslight the victim, accuse them of being the perpetrator. Would you agree?
That's a characteristic of psychological abuse, yes.
Okay, and it's common then for them to accuse them of being the perpetrator, the victim.
That's a characteristic of abuse from women perpetrated against men. It's actually very, very common. About 90% of male victims of IPV have reported that a female partner who abuses them makes threats to report their partner as an abuser. It's less common for men to make that statement to female partners just because there's less potential consequence.
And it's distressing for the victim to be accused, is it not?
Absolutely.
It causes them a lot of fear?
Certainly.
And it causes them a lot of distress?
Absolutely, yes.
And in fact, they feel falsely accused, correct? They feel falsely accused, correct?
Yes.
And they feel paranoid?
Yes.
And they feel frightened?
Yes.
Afraid that everyone's going to believe the perpetrator, correct?
Yes.
And in fact, they're afraid they're going to lose their security, correct?
Can you clarify what you mean by security?
I'll ask the next one. And they're afraid they're going to lose their reputation, correct?
Yes.
Now let's talk about the testing for a moment. You talked about the MMPI-2, but that's not the most recent MMPI, is it?
No, it's the most researched.
Okay. Now, on the MMPI, there was only one section that had elevated scores, correct?
No, that's not correct.
It was the K section, correct?
That's not correct.
Okay. And was there any elevated score over 65 on the MMPI?
I would need to take a look at it. If, I provided a 25-page interpretation outline. If you're able to pull that up, I'd be happy to go over any of the individual scores for you.
Can you recall any clinical scales for the MMPI-2 for Amber Heard that were above 65 as you sit there today?
Again, there are multiple scales on this test, 25 pages worth listed. So if you can pull it up, then I can review and give you a confident answer.
What can you recall as you sit there?
I'm hesitant to do that because I don't want to make an error by ignoring hundreds of scale scores.
And would you agree that you can't make a pathological determination or diagnosis if the scales are not elevated on the MMPI-2?
I would not agree with that.
Well, it's a common trauma symptom, isn't it, to not feel safe?
Sure.
And safety concerns are common among women who have been victimized, correct?
Women and men, yes.
Okay. And memory difficulties. Amber said she felt she had holes. Do you recall that?
I do. And her account was different than typical memory difficulties with trauma.
It is common for individuals who have experienced trauma.
And it's actually not common. No, it's a symptom, but it's the least common.
Now let's talk for a moment specifically about a couple of the profiles on the MMPI. This is not an exaggerated profile for her, is it?
No, actually, that was something unique. When she completed objective broadband measures, where the questions, you don't know what the questions are getting at, they seem completely random. She raised scores that indicated that she was trying to minimize any mental issues and appear completely free of pathology. When she took tests that asked questions that were specific to trauma, that's when you'd see these extreme exaggerations.
Now, is it your testimony under oath today that you have not been asked to testify concerning Ms. Heard's behavior in the context of her relationship with Mr. Depp, including any abuse?
That's correct.
Okay. And you have not made any determinations, including any of opinions that Ms. Heard abused Mr. Depp or Mr. Depp abused Ms. Heard, correct?
Correct. That's outside of the scope of psychology.
Okay. And you cannot testify whether Amber Heard suffered any emotional distress as a result of any of the defamatory comments that she has alleged Mr. Waldman made through Mr. Depp made through Mr. Waldman, correct?
What I can testify is that there was no indication of a decline in psychological functioning showing any injury since she's been with Mr. Depp.
You cannot testify one way or the other on that, correct? Your Honor, may we approach?
Okay.
Dr. Curry.
Yes.
In your report, nowhere in your report did you provide any opinion of whether Ms. Heard suffered emotional distress as a result of the defamatory statements. Is that correct?
That's correct.
Okay, thank you. I have no further questions.
All right, redirect.
Dr. Curry, you were just asked a question about malingering.
Yes.
Is there another test that you did to make a determination with respect to malingering?
Well, malingering is a term that most psychologists, we try to be careful of it because it indicates an intent for secondary gain. I prefer feigning, which you had brought up earlier, because it indicates that somebody is intentionally exaggerating, but I don't know necessarily why. So I think that's a more accurate term in general. On the MMPI-2, yes, there was no exaggerated profile. I also gave her, though, the CAPS-5. I don't know if you'll remember, but that is the clinician-administered PTSD scale. Consistent with the DSM-5, and on that, there were signs of gross exaggeration. I also looked at the test results that were provided by Dr. Hughes, and on an objective test of trauma, there is a scale specific to intentional exaggeration on that test, and Ms. Heard was in the 98th percentile, meaning that she had engaged in extreme levels of exaggeration.
You were asked about intimacy problems, relationship difficulties associated with IPV, and you then said that there were some key differences.
Yes.
What are those?
So what you see when we're talking about the personality disorders is there is a very consistent pattern of the aggression, the violence, the irritability. First of all, it's escalated. But second of all, it occurs when there is either, for the borderline component, a threat of abandonment, a perceived slight, feeling like the person is about to leave you, about to walk away to get some space from an argument.
What? Oh, no, I want to know.
Yeah,
I want to know.
get out your Ubers out.
I'm kind of waiting. You go get it.
Yeah, I'll be in.
Wait, is there no other place for you to run in your 15 other houses to go run? Come on, go be a real married man and go deal with your shit the way that a man does. Go run to the next house. Every man does.
Yeah.
Go. Run away. I know it's hard to
You're
look at yourself.
fucking ridiculous.
It also occurs to a more mild extent, but when there's a loss of attention and a need to manipulate to try to get that attention back. But it's not, when somebody has PTSD, that irritability is sort of at a low, constant level, or it's completely random. It's a very different type of presentation. IPV, it might be more irritability, but that's actually less of a symptom for female IPV victims. Usually what you'll see is somatic symptoms, the depression. A lot of fearfulness and anxiety, but typically more complaints about somatic symptoms. So when you're providing therapy, you're in a very different role than an examiner. When you're the forensic examiner, you're just really looking at data to make a decision. When you're a therapist, you're an advocate for your client's well-being. And in fact, it's considered extremely unethical for a treating provider to ever provide opinion testimony like I'm providing, because it's so well known in our field that you're going to have an automatic bias for your client. It's almost sense of protection, advocacy, wanting their best, which is why we also know that it's very inappropriate to convey any sort of opinion about whether a crime occurred, whether abuse occurred. We can certainly believe our clients. We can support them in their therapy and take them at their word. We're taught, we're trained to stay away from making any sort of opinions, understanding that most of the time, and most of Ms. Heard's providers were just treating Ms. Heard, and they're going to be advocating, and the treatment relationship is about helping your client achieve well-being, not making formal psychological or psychiatric opinions.
Dr. Cohen, treating physician?
Yes, he was a psychologist.
Yeah. Dr. Banks, treating physician?
Dr. Banks, yes, treating psychiatrist.
Dr. Anderson?
Yes, treating psychologist.
Every one of them had to take Amber heard at his word, right?
Yes.